right, thanks everybody. I'm glad to see everybody showed up tonight. We have a full house. So I'm Kristina Connor. I work with the University of Minnesota Cardiology team as a nurse practitioner with Dr. Dan Brody. And we're new here to Grand Rapids for this service starting this past April. We're also serving Hibbing as well, so we kind of bounce back and forth. So I'm happy to see the turnout tonight. So how many of you are familiar with heart failure? Few? So we got few veterans, few that this is new, so we'll cover a lot tonight, so let's get started. The topic here is heart failure. Let's get to the heart of the matter. So here's some objectives on tonight. We're going to talk a little bit about heart anatomy, as well as the definition of heart failure. There's two specific types of heart failure. We'll talk more about that tonight, systolic heart failure and diastolic. We'll talk a little bit about preserved ejection fraction with the diastolic, as well as reduced ejection fraction involved with the systolic failure. We'll talk about different causes of heart failure, symptoms to watch for, treatments that are available out there that can be recommended by your medical team, as well as prevention of heart failure and lifestyle modifications that can go with that. So the heart is like any muscle in the body. It needs oxygenated blood flow to supply that tissue. We'll talk a little bit about the flow of the blood through the heart. So if you think about looking, at your wrist and your vasculature, you see blue. Blue here is venous. This is the blood that's already been supplied oxygenated blood to the tissue, and now it needs to come back up to the heart. And so it comes up through the vein to return to the heart. And where it goes from there is the inferior and superior vena cava. And that's how it enters the heart into the right atrium. So from the right atrium, it comes through a valve called the tricuspid valve. And that blood flows through the tricuspid valve into the right ventricle. Then it moves through into the pulmonary valve, and then it hits the pulmonary artery, and that's where that blue blood gets oxygenated by the lungs. And so now we're good and oxygenated. That blood starts to look red, if you think of it like that. And it re-enters into the heart, and it comes up here into the left atrium now. It passes through the mitral valve into the left ventricle, and then it comes out a valve called the aortic valve, which many people are familiar with. And that goes out into the aorta, and it supplies the body and the tissues with good oxygenated blood. So that's kind of the basic flow of how things move through the heart and the different valves involved. And we'll talk more on how that pertains to heart failure. I'd also like to touch, and we don't see the coronary arteries on this, but you're probably familiar. The coronary arteries are the arteries that supply the heart. And so there's three main coronary arteries that supply the heart. And we want to talk about those tonight because if they have blockage or narrowing, that can affect the blood flow that hits the heart and can cause some symptoms and can cause certain types of heart failure. It's actually coronary artery disease is one of the #1 causes for systolic heart failure. And so if you hear of somebody who talks about having chest pain related to blockage or a heart attack, we say that's kind of feeling the burn. Your heart's a muscle, just like any other muscle in your body. And that pain you're feeling is the burn from what we call anaerobic metabolism when we're not getting enough good oxygenated blood flow to the tissue. And that can cause damage to the heart over the long term. All right, what is heart failure? And basically heart failure means that the heart is not pumping as well as it should. And so there's the two types we talked about, the systolic heart failure and the diastolic heart failure. So some people may have one or the other, some people may have a combination of the two. They come from a few different causes and some the same. The systolic failure is the weakened heart muscle in which that ventricle gets very enlarged and it thins around the outside, and it causes it as a pump to just not squeeze as well as it should. And less blood flow is therefore pumped because of that. The other one here is diastolic heart failure. That's when it gets stiff. Our heart doesn't relax as a pump. You don't find the enlargement of the heart as much in this one, but that wall gets real thickened and stiff, and it doesn't relax as well, and therefore causes similar properties in that the ventricle doesn't pump as much blood that way. This systolic failure, we'll talk about ejection fraction. Some of you may have heard about that when we move on to slides. But with systolic failure, you tend to drop that number of your ejection fraction. With diastolic, we don't see that typically. So moving on to some pictures. Can somebody guess which one's which based on what we talked about? Which one looks like that heart from systolic failure and which one's diastolic? So this is that enlarged. You can see those ventricles are nice and big, much bigger than here. You know, your heart is the size of your fist. And look how thin that wall is. And so that's that thin, weak heart muscle that's stretched out, not pumping as much blood through the ventricles. This one here is the one with diastolic failure. That one here is the thickened heart muscle. It's very thick, you can see, doesn't allow filling as much or pumping out, but the size of the heart is normal for what we should see. It's not as enlarged as the one over there with systolic failure. So how do we know if you have heart failure? One of the main things we do is an echocardiogram. I'm sure a lot of you have had an echocardiogram or have heard of an echocardiogram. And that's a test, it's an ultrasound basically of your heart. And what we take is a transducer and we put sono waves, which are those ultrasound waves, to make pictures of your heart, to look at your heart, the ventricles, the atrium, as well as all of the valves, so we can better diagnose what's going on. This is also called diagnostic cardiac ultrasound. And like we said, sound waves come through and build these pictures of the aorta, arteries, veins, all the structures of the heart. This talks about the probe. That's that transducer that we apply jelly to your chest, move that transducer around. Echo doesn't harm you, so there's not radiation. This is all sono waves involved with this. And there's some pictures of what this looks like when you're having it done in the sono waves that are created. And this is the picture that we get here. And in this one, you can see we're looking at the left ventricle there on the angle of that picture. And of course, we see multiple borders and views of the heart when we do this. If you've ever had it done, it takes a little bit for the tech to move around and get all those good pictures. So based on this, we're able to calculate something called an ejection fraction. The ejection fraction is how we calculate how much blood is leaving that ventricle. So one would think 100% should be a good number, and that's how much we should be pumping. We score 100% on a lot of things. Maybe we should have that with our heart, but that's not true. Normal is anywhere from 55 to 75% for most individuals. So if any of you have heard about your ejection fraction, now you can know if you're in normal range or not. All right, so some symptoms that go along with heart failure. Oftentimes we start with fatigue as the first symptom. So a lot of us are thinking, man, that could be me, right? But then it leads on to other things. It can cause shortness of breath as that fluid backs up into the lungs. When the heart's not pumping as well as it should, that fluid backs up with heart failure, and it can go back in circulation. And that's why it's important we talked about the mechanics of the flow through the heart. You can also get, so depending on whether it's affecting the right or left side of the heart, with the right we can get very short of breath. We can get something called orthopnea, which is when we get difficulty lying flat. You lay down and you almost feel like you're drowning from the fluid. You can't breathe, but you sit back up and now I can get my breath back. Oftentimes with left side we can get more lower extremity edema, basically fluid backup and swelling. So the fluid goes out of the vascular system and it ends up coming into the tissues. So those are those big puffy legs that you can get where you press on them sometimes and you can see your fingerprint in there. And it all has to do with fluid backup. You know, you wake up, it might be okay, but as the day goes on, that gets worse and worse. And we have a hard time controlling that. We can even go as far as getting fluid over our bellies from the backup of this. And eventually the system gets so fluid overloaded and severe heart failure that you can develop organ failure, and that's when we talk about end-stage heart failure. So causes of heart failure, there's quite a few listed here. Some of them look more terrifying, like aging, because we can't prevent all of these things. We'll talk about some of the risk factors first for systolic failure. That's one where we have the reduced ejection fraction. The number one that we found is coronary artery disease, and that's in developed countries. We see that coronary artery disease is the most common. So when we talked about the coronary arteries that supply blood to the heart, if those are blocked, it can cause damage and can be one of the main reasons for heart failure, for systolic heart failure. Other reasons can be valvular disease. These are all things we can see on echo as well. Sometimes we see hereditary components that can cause this. We have a change in some of our heart proteins and our genetics that can cause that. Different toxins, so alcohol is one. Alcohol in moderation we say is okay, but it's in excessive amounts that we see problems with heart failure. So if you come into the cardiology office and we ask you about your glasses of wine and we say, well, how big is your glass? Because one glass of wine isn't always one glass of wine. So otherwise we see with chemotherapy as well. Anthracycline is a group of chemotherapy drugs. It's most common. It's used with breast cancer, and that is known to be more cardiotoxic. Cocaine, meth, drug abuse like that can be a reason for heart failure. Viruses are a reason for heart failure that are out there. This we see pretty seldom. That's a pretty rare finding. We also can see it in a postpartum state related to pregnancy. In that case, a mother who just had a baby would have their OBGYN involved in that as well. And then congenital defects that can cause it, which kind of fits as well in that hereditary zone there. For diastolic failure, we're looking at the one that has the preserved ejection fraction. So it looks like a normal pump, but it's that big, thick muscle that's created in the heart, normal size, but real stiff. That one is mainly due to uncontrolled blood pressure over a long period of time. That's why we really try to encourage your blood pressure meds. Other reasons for that is uncontrolled diabetes. If you're a diabetic, we like to track that A1C. That's a 3-month average of your sugars to make sure you're well controlled there and not worsening things for your heart. We also see females are more common to have diastolic failure, as well as just aging can cause diastolic failure. And with the coronary artery disease being the main cause of systolic failure, if you come into the office and we notice that your ejection fraction has dropped and that's new for you, oftentimes we'll want you to go do an angiogram. That's a catheterization where we can look and see if you have any blockage that could be causing this before we start saying this is a long-term condition for you. See if there's any way we can reverse the effects. So, what are effective treatments, or are there effective treatments that can prolong my life? So most of the studies up until this point have been around systolic failure, the one with the reduced ejection fraction. There was research in the 80s and 90s that revolutionized the care of systolic heart failure, and so it hasn't been too long since we've really, made some huge strides in how we treat heart failure and prolonging people's life. And so we know in heart failure, when your body goes into this fluid overload, things start backing up because that heart's not pumping as well. Or we give off hormones in the body that respond to this reduced cardiac output. And this can negatively affect the heart and other organs. And by blocking some of these hormones, controlling your heart rate and how hard your heart is working, we can help either postpone the progression of this or maybe even sometimes improve things. When those don't work, we oftentimes will put in a defibrillator, and that's when your ejection fraction has dropped really low. So we talk about normal being 55 to 75. These are people that are anywhere from 10%, 15% ejection fraction. What we know about those people is when your ejection fraction is quite low, you can go into an abnormal rhythm that can potentially be a life-threatening rhythm. And so putting in these special pacemaker wires that have a defibrillator, we've found that we can save people's lives that have advanced stage heart failure. They can be shocked out of an abnormal rhythm. Other things we do is some special pacemakers. This is different than the defibrillator. It's a biventricular pacemaker, and that can just help keep things in sync so we don't create those dangerous rhythms as we get in the more advanced stages of heart failure. And so what we see with this is we get less hospitalizations, improved outcomes, increased survival. Medications that we usually see with this as well are, you might have heard of beta blockers. We use something called ACE inhibitors, angiotensin receptor blockers, medications that block different hormones like aldosterone that can help with fluid overload, as well as your basic diuretics. There's some potassium-sparing and non-potassium-sparing diuretics out there that are basically our water pills we hear about when we help control our fluid. And then advanced stages where there's more drugs coming out on the market now, and Tristo or Entresto is one of them. We also have used digoxin for many years too, so some of you might be familiar with some of those medications. So what happens if we're beyond the point of heart failure that we can control it with these medications and some of these adjustments in lifestyle that we'll talk about soon, these defibrillators and other things where the fluid starts getting so backed up that our mortality risk is quite high? So we've done cardiac transplantation for this for quite a few years now. The University of Minnesota was one of the first successful facilities in the state of Minnesota to do a cardiac transplant. And so with this, we find that we only have a few transplants that happen compared to our population per year in the United States. It's 2,300, and that number has been pretty steady for the last few years. The reason for that is first of all, it's hard to find a heart, and the heart can only be out of the body for 4 hours before it begins to have damage. So from donor to going into the recipient, you have a very short amount or window of time to keep that heart viable. And so there's many issues that come up, like, what if I'm in Minnesota and my heart's in Arizona? These things can't happen, and there's a lot of other underlying things. You'd think maybe you just go over to the state where there might be a heart or somewhere you think there is one, but it does get more technical than that. So for who's a candidate and not, and if you're a candidate for a transplant, they work with program coordinators to get you enrolled to find a heart. If you're waiting for a heart, you think, well, I don't have much time to go, then what do I do? And that's when what's called a LVAD, or a left ventricular assistive device, was created. These LVADs are pretty amazing in that they basically have this large port or this large line that comes from the left ventricle and pumps the blood up to the aorta, because we know that ventricle is failing as a pump, and so it acts as the pump for you. It has a little control center that is actually battery powered, and it runs through the abdomen, this line, to the actual LVAD machine itself, and you literally run on a battery for 8 hours. You have a backup battery, and then you literally plug yourself in at night when you get home. So it's not the most convenient way to live. It's not the best quality of life, but hey, if this is going to keep you alive, this is pretty amazing. I'm sure many people in this room are familiar with Dick Cheney. Everybody knows Dick Cheney, right? So he actually made the LVAD known to the public. Dick Cheney had an LVAD. So his source of his heart disease, because he's come out to public on this, was coronary artery disease. I think he was in his early 40s, maybe even late 30s, I think it is. You'd probably be able to find it online, that he had his first heart attack, and he had multiple heart attacks through his life. So coronary artery disease caused his heart failure, and as it progressed, he eventually got to end-stage heart failure, and he ended up having an LVAD up until he got a transplant. So he was also a heart transplant recipient. Pretty amazing stuff, huh? So we've got a lot to work with. Of course, you're not going to get your LVAD or your cardiac transplant here in Grand Rapids, but at the University of Minnesota you could. So I did see coronary artery disease prevention here because it is such a large cause for systolic failure. So what things can we do to prevent coronary artery disease? Number one, don't smoke. You wouldn't believe the amount of coronary artery disease we see solely to smoking. And people who have gone for stents and other procedures, that those just end up getting blocked up in a short amount of time because of smoking. Controlling your cholesterol. So if you go into the office and They ask you to have a fasting lipid panel where we're looking at your total cholesterol, your good cholesterol, your bad, your triglycerides, all of that. It's all part of the equation, and that can help prevent coronary artery disease and therefore help prevent heart failure. Blood pressure control, that goes in both heart failure specifically as well as coronary artery disease. Weight management as well with healthy diet and good control of your diabetes. For heart failure, more specific things, if you have sleep apnea, you have concern for it. Sleep apnea can actually be a cause of heart failure, can worsen it as well. So we want to make sure you're treating that. I know a lot of people that have said, I'm diagnosed with obstructive sleep apnea, but I can't tolerate that darn machine. And that's why we try to work with you to find one that works for you at the right settings, because if you're not using it, we're not treating it. So diabetes, again, controlling your diabetes, weight management fits again, and then the moderation of alcohol use, of course, avoiding drugs and some of those things that we talked about before. If you have cardiac heart failure as well, or congestive heart failure, either systolic or diastolic, a lot of times we'll want you to do cardiac rehab. Just like you hear about it with coronary artery disease and different procedures you might have done, rehab also helps out our heart failure patients. All right, so we like to look at risk scoring as well based on coronary artery disease risk. So we're hitting that up pretty hard with heart failure tonight. We look at a Framingham risk score a lot, or a risk calculation that estimates our 10-year risk of heart attack. And now public health data has shifted in. We're not wanting to focus just 10 years. We want to look 20, 30, many years down the line. But most of our risk scoring is based on 10. So if we can continue these cycles, we hopefully can reduce it long term. So age, that's one we can't control, of course. So we look at some markers here to help calculate this with our Framingham risk scoring. Gender, so male, female is part of this. Smoker, so the first two you really can't control, but now we're getting into some that you can modify. Total cholesterol, so by reducing that cholesterol, we can knock points down from that. We want to make sure your HDL is up. That's your good cholesterol. Some of the statin medications out there can help improve that, but a lot of that is diet alone that changes that. And so that's the protective cholesterol. So oftentimes we look at that's the number, you think, why that one, you guys want that one high and the rest low? What's going on here? And that's because it's protective. And we actually use that in this calculation. We look at your systolic blood pressure. That's that top number of your blood pressure reading to see what that is. And then we ask if your blood pressure is treated with any medications. And by doing this, we get an estimated average of what your 10-year risk, percentage for your 10-year risk for heart attack. And we know that aspirin helps reduce your risk, and for people that are found at risk in this risk score, taking a daily aspirin, just a baby aspirin, 81 milligram chewable aspirin, can help reduce your risk for coronary artery disease. Studies show up to 30%, so that's pretty amazing. Of course, you'd want to talk to your doctor before you go starting it, because some of us have either kidney disease, we've had bleeding issues in the past, and that can change whether you're a safe candidate to be on that aspirin, or you might be on other forms that are like aspirin, Plavix, Brilinta, things like that, that we may not want you taking it together. So make sure you talk to your doc if you're interested in getting on aspirin. So in conclusion, if you're concerned about heart failure or you have any other related concerns to your heart, you can come see myself or Dr. Brody, and we'd love to meet you and talk about anything related to your heart. That is our pride and joy, your heart. So with that being said, one other statistic that I thought was interesting from the American College of Cardiology, we see it as the American Heart Association has shown that 1 in 5 people these days will develop heart failure. That's a pretty high number. That's not divided out by systolic, diastolic are the two types, but we know that 1 in 5. So if you look around the room, that's quite a few people that are affected. We're going to move into the University of Minnesota's services here, and so we're part of mHealth, serving Grand Itasca as well as Fairview-Hibbing Range. Right now we're on the same rotation, but eventually we're going to be flipping, so we'll have coverage at each site 5 days a week. So you might have seen these faces around. So this is a little bit about M Health and the services we offer. So we're a part of this big organization out of Minneapolis there in the center. We do preventative cardiology, 24/7 emergency treatment, but most of the time here, because of where we're located, if you go in with a heart attack, oftentimes you're going to Duluth, because we look at that time frame from your EKG to when you're on the table getting the angiogram. So that's a little bit different, but they offer that too. They have a cath lab, so if we refer you for an angiogram to check for blockage and you might need stents, angioplasty, things like that, or even a bypass, CABG, you could go to the university as long as you were stable, and we've referred a lot of patients there where they've drove there for the day and got the procedure done and they come back, so it works out pretty slick. Advanced heart failure treatment diagnosis, so looking at managing heart failure as it gets more advanced. That's where they're doing LVAD, heart transplants. The team there is working with that. Cardiac device management, so now we're looking at the electrophysiology of the heart, those heart doctors that we call the electricians of the heart, anything from pacemakers to ablations. Some of you may have heard some of these words in the past. We offer all of those services. Cardiac imaging, surgery, heart transplant, stress tests, and the list goes on, of course. So a lot of services that we don't have close to home, which is nice. Some fast facts about the U of M. It's one of the largest systems of cardiologists in the state of Minnesota, more than 50 cardiology programs out there, and we're serving 11 Fairview locations and 3 outreach sites. Grand Itasca is one of those outreach sites. All right, so major firsts of heart failure at the U. World's first successful open heart transplant, first heart transplants in Minnesota, state's first heart and lung transplant, some of the first clinical studies in heart failure, and it continues to be studied. Diastolic failure is being more studied right now. That's the one that we have not had as much study about as a systolic, and it's a little bit harder to treat. As well as the implantation of the first partial artificial LVAD at the University of Minnesota. Thanks, everybody. Thanks for coming out tonight.